This podcast is for informational purposes only and does not dispense medical advice. Always seek the advice of a physician or other qualified health providers if you have any questions regarding a medical condition. Never disregard professional medical advice or delay in seeking such advice because of something you have heard on this podcast.
Hi, this is Shay. Thanks everyone for listening. Oh my God, today we had an amazing show. We just finished interviewing Dr. Adam here in Chicago from Northwestern Medicine Hospital. It was so enlightening. It was full of hope, joy, and it was not so dark. We talked a little Marvin Gaye, how to get that, sexual healing back. Prostate cancer is a very serious disease, but there is light at the end of the tunnel. Enjoy our conversation with Dr. Adam Murphy here in Chicago from Northwestern Hospital.
Welcome to a show that we like to call Prostate Cancer Real Talk. Did you know that in the U.S., 1 out of every 8 men will be diagnosed with prostate cancer during his lifetime? 1 out of 8. And Black men are 50% more likely to develop prostate cancer in their lifetime and twice as likely to die from the disease. But hey, we're not here to quote statistics and tell you how tough prostate cancer can be. Rather, we are here to create a supportive community of survivors, a place where we can discuss the real-life coping methods from the perspective of a married couple who are living through it day by day. Our hosts, Elle and Shay. This is Prostate Cancer Real Talk. In this episode, we welcome Dr. Murphy. Dr. Murphy is an assistant professor of urology and preventative medicine at Northwestern Medicine and on staff at Cook County Health and the Jesse Brown VA. He has been studying the health disparities faced by minorities in prostate cancer, looking at the role of vitamin D deficiency, genomics, and biomarkers and disparities for men at risk of and already diagnosed with prostate cancer. Dr. Adam joins us today to further his community outreach and to continue his mission of education and prevention. Let's find out more about Dr. Adam. Elle, take it away.
Thank you very much, Dennis, for that great introduction, and welcome again to Prostate Cancer Real Talk. This is Elle, and I'm here with my wife, Shay. Hello, Shay. How are you today?
Hello, Elle.
So we're very fortunate to have Dr. Adam Murphy with us today. Dr. Adam, so why don't we start out by asking you to give us a little overview of what your specialty is and any comments that you'd like to make to our listeners as we discuss the topic of prostate cancer. And specifically today, we're going to be leaning toward the discussion of Black men and prostate cancer.
So first, Elle and Shay, thanks for having me. Dennis, thank you for that great introduction. I always sound better in other people's mouths than my own. It's really an honor for me to be able to be a part of something like this where you're doing community education on something I'm really passionate about. My father and grandfather are both prostate cancer survivors. And so I've seen the impact of this disease in the Black community. My godfather actually died of prostate cancer at the VA that I work at.
Oh.
So and I just think this is a great thing that you all are doing. I guess I would say to kind of talk about what I do is I'm 50% general urologist. So I treat patients. I am really an advocate for patients making informed decisions. And that's why I'm really about health literacy and kind of public education. And then I'm also 50% researcher. I have a lab at the Jesse Brown VA and at Northwestern University focused on basically the reasons why African-American men have prostate cancer more often and more aggressively. And more recently, I'm focused on precision oncology and making sure that these great tools and tests that we use in prostate cancer to diagnose or, predict kind of outcomes, make sure that they work and make sure that they're usable and affordable and insurance covered for African Americans.
So, along those lines, why do Black men, I know this is what you're trying to solve. You don't know the answer, but give us some insight in terms of why Black men are so prone to this disease.
It's an interesting question you ask. It's very loaded. because there's, there are twin studies that they do to kind of see how much of this is genetic, right? And somewhere between 33 and 45% of it seems to be genetic. So family history is the biggest, one of the biggest risk factors besides age and Black race. And so when I first got into this, I thought the Black Race Association was really due to our West African ancestry in that it was a genetic defect and somehow. And I'm not sure that that's true anymore. We got to do an autopsy study in Nigeria, actually, and we found that the rates of prostate cancer in Nigerians, our motherland, for at least 70% of Black Americans, they have much lower rates of prostate cancer than even white Americans. So right now, my thought is that it's, social determinants of health, and it's kind of what we call gene-environment interactions, where the genetics that we had in West Africa made it so that our rates of prostate cancer were pretty low. But when you expose that genetics to the American environment, and that also applies to the United Kingdom and Europe, something about what we do differently in that environment increases our risk. And for that can be lots of things. It can be the diet. It can be vitamin D deficiency, like I study, and sun exposure. It could be stress. It could be systemic racism. It could be lots of things about how we access healthcare system. So it's a mixture of things. It's not like, cigarette smoking leads to, lung cancer, or HPV leads to cervical cancer. It's a lot of causes, and that's the reason why it's so complicated.
I see. As we're talking to our listeners about this disease, what are some of the things that a man, any man, Black or white or any man at all, what are some of the things that we can do to perhaps prevent it? And then I'd like for you to also include in your response to this question, talk about testing and the role that early diagnosis plays in this.
Al, I didn't pay you to say that, but that was exactly where I was going to go.
Okay. I read minds too. I forgot to say it.
It's like you've done this before.
I have.
No. So what can we do for prevention? I mean, number one, I think that I want people to realize that they should be screened. Because of the controversies in PSA screening for the population in general, I think it's persuaded a lot of primary care doctors to not screen for prostate cancer. But I think that message really hasn't applied very well to African Americans, because it's done a disservice, because, as you said earlier, there's 50 as high as 70% higher risk of prostate cancer in our community. So the benefits of screening are higher for Blacks than the general population. So right now, screening gets the letter C, a grade of C, from the U.S. government for screening, meaning it's up to the patient and the physician to have a conversation to talk about that. That the benefit of screening is probably a lot higher in a group that's had it more often and more lethally, right? And so for African Americans, the American Urological Association, which is, who gives us our guidance as urologists, they say starting at age 55, and kind of say the decision should be earlier for African Americans, but it's a discussion, right? Mm-hmm. So what we tell people now is starting at age 40, you should get a baseline PSA. And then if it's above the median for your age, which is 0.7, you should be getting screened at some interval every other year, perhaps, from 40 to 55, to make sure that you're not one of those people who progresses to a significant cancer. If you're below median, you don't have to probably screen again until at least age 50, maybe even 55. So if you catch the people who are above the median level at 40, you capture 90% of the people who would ever die of prostate cancer. So there's a lot of data behind that strategy.
Okay. So one of the terms that you just used was PSA. So those of us on the call, we know what that is. But to the listeners, what is a PSA? What is that?
Thank you for asking that, because people call it a PSI per square inch because they're used to filling their tires. And that measure means something to them. PSA is Prostate Specific Antigen. I got to work with a guy who is kind of the father of the PSA test, Dr. William Catalona at Northwestern now. And it's still the preferred screening test to see when people should get biopsy. And in general now, people are saying if the level's above 4, you should get a biopsy. The main way we detect prostate cancer, but it's not the easiest of measurements to work with, because there can be people who are missed who have a PSA less than 4 that still have, significant cancer. But in general, that's what we use. And the reason why we talk about using it every other year is because sometimes changes in the PSA, especially big jumps, are signals of cancer too.
Mm-hmm.
So, anyway, PSA is a big test.
That's what happened to me, actually. And so, to be clear, the way that they gather the PSA, it is a blood test. It's not a urine test. So your urologist will actually draw blood from you, and that's how they run that test. And I know that some men are reluctant to get tested for prostate cancer because they're still thinking about the old finger test, if you know what I mean. But the PSA is more precise than the finger, correct?
So the PSA test should be done by the primary care doctor too, not just a urologist. We confirm it. That's 1. 2, the PSA does detect about 80% of the prostate cancers by itself, but you can detect another 15% with the rectal exam. So it is an important part of the screening exam that should still be done at least every other year. Okay. Now, people who don't want to have the PSA, who don't want to have the rectal exam, it's definitely better to do the PSA than not do either test.
Okay, so Dr. Adam, you said that 50% of what you do is research. So I'm wondering if you could answer this. Now, in L's case, he had that spike sort of like all at once. Like his PSA was normal. It was just always normal. And then all of a sudden there was a spike. I don't know if you know the answer, but that just blew my mind. Like all of a sudden he came home and say, there's a little concern. My PSA level has elevated. It was like out of the blue. And I was like, okay, well, what does that mean? And he's like, well, the doctor want me to have further testing. They kind of want to monitor it, and they want me to come back again in 3 months. And when he went back, it was even higher. And then that's when he had to have the biopsy, then, of course, with the diagnosis of having prostate cancer. So that was really shocking for me that it just kind of spiked like out of nowhere.
Yeah, we're lucky in that that's kind of what happens for a lot of people. And I know with your story, they're all individual stories, so I don't want to conflate them. But when you see tumor cells, what tends to happen is that you go from this like really kind of normal cell, prostate cell, and then it accumulates these mutations, genetic damage to their cells. And sometimes it's not actually mutation, sometimes it's suppression to what's called epigenetics, where your diet, your sun exposure, your stress, all that can do changes to the DNA, but not actually make a mutation, okay? It can suppress the expression of abnormal growth, right? It suppresses abnormal growth or tumor suppressor genes. But anyway, the point is that at some point it accumulates enough changes where it starts to act like a cancer. The normal checks and balances that the cell had to prevent it from actually going out of control, and your cells have a lot of those checks and balances. At some point, you accumulate enough damage where those checks and balances are no longer working, And all of a sudden, this tumor that was kind of low growing and small and being kind of kept in check by your own body is now evading the immune system, or is now recruiting blood vessels to come to it. And that's what brings the PSA levels up. It leaks more PSA into the bloodstream because of the extra blood vessels.
Okay, so are all prostates created equally? Meaning what?
The constitution of prostate.
Seriously, like, so
they're not all created equal.
Okay, I didn't think they were. Okay.
The reason why I say that is that some people are already born with mutations in certain genes that are tumor suppressors, right? Uh-huh. And they need less damage to happen for them to become a cancer. And then the rate at which we accumulate damage to our DNA or our epigenetics also depends on what we're eating and how we're stressed, right? Mm-hmm. If we're around cigarette smokers or we're alcoholics at some point. So maybe at birth they were similarly equal, but again, there's hereditary prostate cancer. So we know for a fact that they're not all created equal.
Okay.
And to that point, I had a conversation with a gentleman who is also a prostate cancer survivor. As a matter of fact, he's going to be on the show with us at a later date. But he said his PSA level went from 2.5 to 5.5 in 8 months. Mm-hmm. And then in the next three months, it went from 5.5 to 7.0. So, is that an indication of an aggressive prostate condition? What do those numbers say? How do numbers quantify the risk of prostate cancer?
So there's two different concepts that both predict kind of either mortality from prostate cancer or recurrence after you've gotten treated for prostate cancer. And it's called the PSA doubling time. So the faster the PSA doubles, goes from 2.5 to 5 to 10, is predictive. So if it's less than 2 years, that's a risky doubling time. If your PSA velocity should go up about 0.35 to 0.70 per year, and if it goes up more than one a year, that's a risky number. So yes, you're right. The PSA changes are a proxy for the tumor growth, the growth rate of the tumor.
And I know I'm asking a lot of questions. I guess that's why we're here. But, when you're talking about prostate cancer and whatnot, and particularly for Black men, it brings to mind the vaccine that we're talking about with COVID. Some people, are reluctant to take the vaccine because of one thing or another. And I always say, what are you afraid of? You think you're going to wake up with goat horns or something in the morning? What do you think is going to happen that's so terrible? So when you talk about prostate cancer, I don't know why men, and particularly Black men, would avoid going to their doctor and getting tested regularly for prostate cancer, particularly, like you said, when you're around 40, just go and have it done. So one of the things that we want to do with the show here is to really encourage people, and I'll use the word encourage because I like to say something stronger, but get your behind to the doctor and get tested. Talk about testing, prevention, and how critically important that is and what difference it makes for mortality rates.
I think you asked a great question, and I think you are on the one end of the curve, bell curve of people in seeking health promotion. You talked to me about that you've been going to Northwestern for years, and I have a lot of patients who don't have as much trust in the healthcare system that you do. And this is probably why you're doing this show, because you see the benefits of it. But a lot of my patients say that every time they go to the doctor, they get bad news, right? And that we are bad news deliverers or drug pushers, and they a good way to avoid stress is to not know there is a problem. Of course, it's a dangerous solution, right? There is a danger to putting your head in the sand. But when we get overwhelmed with too many negative pieces of news, we can't handle it all. And I mean, I think that you see that with the whole COVID response, right? People wanting to deny the need to wear masks, people denying the reality, thinking it's a government hoax, is because we don't want to deal with stress all the time. We want to live our normal lives. And I think this is just another example of it's too much. It isn't healthy, but I think it's too much for some people. Mm-hmm. But I think you're right. The right answer is go in and be proactive. I used to give them the message of when I turned 31, which is several years ago now, I wanted to go to the doctor every year because I was a physician who did not have a primary care doctor, right? And I was a busy resident and I had a family already and was like, I don't have time to go to the doctor. I'm healthy, I feel great. But then I started to realize, well, I could have high blood pressure or high cholesterol. And it would be years before I would actually realize, that I was doing damage to my arteries, my heart. Maybe I was going to be a pre-diabetic, that, you gain 2 pounds every year and all of a sudden you creep into diabetes space, right? And I just wanted to know ahead of time so that I could be managing these problems as I go. But it's a very, very kind of health promoting decision. That's not most people don't make that decision.
When you see patients, okay, and I would say a large percentage of your patients, would you say are Black men?
Yes, they are now.
Okay. So do you have to give the prostate cancer diagnosis to a Black man? Is that something you do? Okay. So here's my question. I know Black men, as you do. And so it's they're all about their manhood, So when you're sitting and you're giving them that, dreaded, diagnosis, oh my God, I'm sorry to say, but you have prostate cancer. Do you explain to them or do they understand in that moment their potential side effects from having prostate cancer? And if they do, is that a determining factor or part of their decision-making process as to whether they're going to have the surgery or not?
You asked some loaded questions, guys. These are great questions, but the answer is all over the place. Like there are people who had a family history or a friend who had prostate cancer, and so they are much more aware of what the prostate is. I go to churches a lot to do talks pre-COVID, and most men don't know that it's not a prostrate. It's a prostate.
Yeah.
And I'm not just saying Black men, I'm saying men across racial groups. They can identify on their body where a woman's ovary is, where the uterus is, and where the cervix is before they know what their prostate is. And they definitely know what those organs do in a woman much better than they know the prostate's function in themselves. And I can't figure out why that is. I think we're very motivated to know about women's health for our own sexual needs, if we're straight, or we also are motivated to probably avoid baby making until we, try to figure out what's going on, right? I know men who can count their women's cycles, right? Like, it's ovulation day, but they don't know what their prostate is.
Do they make that decision about surgery knowing the potential side effect that it could be some sexual dysfunction, or there could be a while before, you're listening to Marvin Gaye again?
I think the reference is about are they aware of the sexual side effects when they're making this decision? It's our urologist's job to do that work, right? But I've done amazing counseling sessions in my own mind that the patient didn't take home with them, because it's got to be to hit them at where their health literacy is, right? So I draw a lot of pictures. My clerks make fun of me because I'm always drawing pictures about where the prostate is and what it does and how it connects to the bladder and the urethra, and the nerves come in right next to it for erection, to help them understand the basics of what surgery does, what radiation does, and what a biopsy is really doing, right? So that they get what just happened to them. So if someone forces me, I'll try to figure out for them what their priority is. Is your priority in life the number of years that you live, the quality of life in terms of sexual performance, or the quality of life in terms of urination and kind of feeling your best self energetic-wise? Are you forming a new relationship with someone where you need your sexual function for the next few years? A lot of single guys out there who get prostate cancer diagnosis and they're dating someone new after a divorce or whatever. I don't necessarily recommend surgery for those folks if they need more time to cement their relationship with their new partner, because sexuality and intimacy is a big part of that. And I can throw a monkey wrench in. Mm-hmm. So I try to figure out what their priorities are. And then I still end up sometimes giving my recommendation, and I will rank them. Here are your 4 options. I would rank this 1 for this reason, this 2 for this reason, this 3 for this reason. This is my last choice for this reason. And then they can accept my answer, or they can go home and think about it and come back.
One of the key determining factors in my selection, or our selection, I'll say my wife and I, and our selection to go with the surgery, okay, was the fact that when I was told by Dr. Kundu that once you get radiation treatment, mm-hmm. there's no longer the prospect of having a prostate surgery. So, it's kind of like a one-way street. And I did not want to go down that one-way street. I didn't like the prospect of being locked in to treatment forever. Because, once you make that decision, you're there. Can you comment on that, please?
I can. I tell patients the same thing. People do what's called a salvage prostatectomy after radiation. It's done by very few urologists out there, and it comes with more side effects. And so, by and large, those are pretty rarely done. It is possible to do them. And it's pretty much reserved for people who are fairly young, like in their 50s, who need to be around because they'll deal with the side effects because it's more important for them to be saving for retirement and paying for their kids and those kinds of things. You may make a kind of desperation play for those folks. In general, that's true. Because you're right, you get this, 20 to 35% of men will have a recurrence after these treatments, radiation, surgery. And when you have them, you want an option if you're still young enough to deal with it.
I want to go right back to the very basics. And part of the reason why we're here is to educate people. And this is kind of a sensitive subject, but, in the men's room, we have no privacy. We talked about the guy that's standing up there for 3 minutes trying to urinate, okay? And, yeah. and you really want to tell that guy, man, you need to get your prostate checked out because it shouldn't be taking you 3 minutes to start peeing, all right? Talk about some of those basic signs that guys should be aware of to let them know that they might want to get their prostate checked out.
So you bring up a good point. And as a urologist, I'm eavesdropping on urination all the time, which is really weird. When we used to go to the old White Sox park and they had the trough urinals, and you just sit there and be like, wow, this is you're still there? I went and got I got popcorn and peanuts, and then you're still. That definitely it was an issue. I have mentioned and tapped people like, I'm a urologist. You okay? So definitely, I'll talk to you about this. One of the issues are that benign prostatic enlargement or hyperplasia, BPH, and prostate cancer are 2 separate diseases. They often occur in the same prostate because up to 80% of men will get benign prostatic enlargement. And you told the people the numbers, 1 in 7 men on average will get prostate cancer. So they oftentimes coexist. They are both about too much proliferation, too much growth in the prostate. And so there are some risk factors that overlap, like age, and vitamin D deficiency being a risk factor for both, and family history being a risk factor for both. Benign prostatic enlargement happens because testosterone is the main growth factor, and actually dihydrotestosterone, the most potent version of testosterone, is a growth factor for the prostate that hits when we males go through puberty, genetic males go through puberty. And because we have this facial hair growing out of our face and, a little bit more muscle and bone mass, the testosterone is always surging, making us more sexually interested, making our prostates grow every year, which is why the PSA changes and increases every year a little bit. And that's also why, as you get older, you can see that urethra that runs right through the prostate like a cored apple can start to choke on the urethra and make urination much harder. So that benign growth is happening, and it can make it feel like you're urinating from a hose to a drinking straw to a coffee stirrer. That blockage makes your bladder work very hard. And so if you are having to urinate and it takes you force to urinate, that's a sign. If you're getting up in the middle of the night to urinate a lot, that's a sign. If the urine is dribbling out and not streaming out, that's a sign. If it starts and stops when you urinate, that's another sign that your prostate has grown big and it's starting to choke off your urethra and make your bladder work too hard.
So then if a gentleman is finding himself getting up several times a night, I would imagine that most guys do get up occasionally at night to urinate. What's the magic?
Not most. That's the issue.
Yeah,
it's not most. It's very individual, right? There are people who are 50 and I don't get up in the middle of the night to urinate.
Okay.
I'm in my 40s. So just to give you some context.
Okay.
But by the time, and I actually try and live a diet that doesn't allow my prostate to grow so fast. If I keep living, my father was getting up in the middle of the night to urinate in his 60s, right? And so the answer is very individual. There's a lot of variation around it. But yes, so if you're getting up more than once or twice a night, if you are finding that you have difficulty emptying your bladder, if you find that you ever have a urinary tract infection or blood in the urine, or you can't pee at all, you are way into it, and you're on the later end of it, and you need to have been in a urologist's office a lot earlier. We treat benign enlargement because of the fact that it's bothersome to people. Rarely is it dangerous, but it's oftentimes can disrupt sleep, make people get up, and poor sleep actually causes accidents and bone breaks and fractures, and can really be significant injury to people as they get older.
We were talking about, you mentioned nutrition and diet a few times. So we like to be informative, but we want people to know, like, it doesn't have to be like a death sentence. You know what I mean? Like there's hope. So let's talk about, what do you think some things that people can do diet-wise? Maybe foods they can eat, things they can stop doing. You can get your groove back eventually. We know that. So we don't want people to think like, oh my God, if I have the surgery, if I get prostate cancer, hey, sex is over. I'm done with sex, my life is over. So what are some of the things in terms of diet? And then we want people to know, like, hey, you can start back listening to Marvin Gaye. You can get your groove back on. It ain't over.
Elle, you've been playing a lot of Marvin Gaye. That's what I've learned.
Yeah.
That association is very strong.
When you want that moment, when you want to hit that thing, you got to go old school. New school ain't doing it like that no more.
Honey, you don't tell everything, okay? Don't tell everything.
Prostate cancer, keeping it real talk.
Okay, a couple things. One, when you're talking about prostate cancer, I would tell people, do not wait for signs and symptoms of prostate cancer, because it's too late. If the cancer, which usually grows on the outside, away from the urethra, is choking off the urethra, that's a big tumor, right? If it's causing you pain, that's a big tumor. You will get some men who will have prostatitis because they've blocked off some ducts in their prostate and probably caused an infection because of blockage. That will present that way, with burning urination, pelvic pain. That means you should go in for a prostate check, but that's more symptomatic of enlargement, not necessarily cancer. So cancer should be a screening test of asymptomatic people, to finish that line of thinking off. If you are having prostate problems with urination, please go see a urologist, talk to your primary care doctor about a referral. Now for Shay's question, prevention. The biggest way to prevent prostate cancer that we are aware of now tends to be about, one, getting screened so that you can catch it early so it's not deadly if you do have it. Two, diet is important. So it seems like red meat, and so a plant-forward diet, a plant-based diet is healthy and has been shown to lower the risk of prostate cancer. The diets that seem to be most like that is the Mediterranean diet, which is more plants, and meat is really for seasoning, flavoring foods. It's not the main course. Plant-based diet doesn't mean you have to be vegan or vegetarian, but it does involve low dairy. It involves low red meats. It definitely involves low, high temperature cooked red meats, and processed red meats. So like pepperoni, salami, deli meats is processed red meat, right? I love Spam as a kid growing up. Don't eat Spam, right? For the prostate purpose. High temperature is like wok frying, deep frying, barbecuing, where there's a lot of char on it. That's the cancer causing part, which tastes so good. I blame God for making everything good tasting bad for you. I love the Lord. Don't strike me down. But it's a shame that so much good stuff is bad for you. When it comes to fruits and vegetables, it's eating the rainbow. It's literally multicolored. But the things that are best for prostate are cruciferous vegetables. So kale, collard, spinach, arugula, the leafy vegetables that have curls on the end of the vegetable, right? Cruciferous vegetables. And then tomatoes. Lycopenes in tomatoes. Cooked seems better than raw. That's prevention dietary-wise. What can you do non-dietary-wise? Maintaining a healthy weight, not smoking, not drinking excessive alcohol, and fish seems to be helpful. As long as it's not fried, it seems to be helpful.
I want to just make a quick comment about the diet, and we'll have a whole show on diet. But, they're coming out with more meat alternatives. Shay does not eat meat at all. She's been that way for well over 10 years.
25 years.
25 years. And so that means that, I get hit by a friendly, non-eating meat fire, okay? So I don't eat a lot of meat either because she doesn't. We eat a lot of fish. There are a lot of meat alternatives out here now. We get those, what do they call those burgers, honey?
Beyond
Meat. Beyond Meat, and they got
Impossible.
Italian. Yeah, Impossible. And I make Italian sausage, with that Impossible, Beyond Meat, whatever. You wouldn't even know the difference. So there's just so many alternatives. So we're going to have a show on alternative meats and eating and whatnot. So
they're trying to make those meats healthy. They're not necessarily healthy yet. They're just not red meat. And so I think for the benefit of the environmental impacts of eating beef and red meat, all for it. I think if you're a meat craver, like I am, I have definitely been pro both Beyond Meat products and the Impossible Burger products. I am for it, but I can't say that they are healthy, right? I can say that they are not red meats.
Mm-hmm.
They shouldn't have the effects of red meat, but they also have been working on the formulas to make them healthier.
Yes.
Okay.
There's a lot of coconut oil and saturated fat and other products that brings that together, right? I'm not saying that you shouldn't eat it at all. I'm just saying I don't know we can't put it in the healthy category yet.
Right. And we also eat a lot of fish too. Are you going to shoot that down too? We got to eat now. Come on.
I want you to eat bread and water. You're a prisoner. No, I want you to eat the rainbow, and I want you to definitely eat meat if you want that in your life, but in moderation, and make lean, healthy choices if you're going to do it. I'm actually the case for moderation. It's just that most people don't do a good job of moderation. Mm-hmm. But I definitely am still a meat eater. I'm a fish eater. I'm an omnivore, but I just really choose my meats well.
Okay. So as we kind of wind down, the last thing I want to talk about today is support. What do you say about the support mechanism available for people who have got prostate cancer?
I will say that prostate cancer is one of the more difficult cancers to understand for patients because of the different treatment options that are there, the lack of knowledge around what the prostate does, kind of what these side effects will mean for you. I think that's, and then also, when you go and you have early prostate cancer, you have to go through, let's say, radiation. You may be going for 43 treatments over 5 days a week, and you may get tired during that. You may have a side effect. So there's marriages and partnership, intimate partnership is one level of support. Then you have your family who can be either a hurt or a harm, depending on how they help you through that. They can be a stressor, or they can be a real boom, a real support. And then there's people who are in support community, like us too, which I'm on the board of. There's support groups around the city that I also work with the Apostolic Church of God, and they have a prostate cancer survivor group. And so having other caregivers and other survivors or prostate cancer patients in a group to talk about this issue is another level of support. But I think that you need support to make these decisions well, because we cannot ignore the fact that your relationship will change because you're going through cancer treatment. We can't ignore the fact that this will have an impact on your partners. And so even how you tell your partners who you talk to is a big deal. So I always try to encourage men to bring their partners in, or their trusted family member or support person, sometimes it's their best friend, into that meeting. So that someone will hear you, hear the doctor give this information and actually can absorb some of it. Take notes even, right? So that you can know what that doctor said. Because if you hear cancer, most men are like a deer in headlights. They only heard cancer. They didn't hear me tell them about the sexual side effects or what they value most. And all they can say is, Doc, you make the decision, because of the emotional fight or flight response that's happening. So to me, the men who have loving partners or loving family support that's really in there with them, they make the best decisions. They feel the best during it. So I really, really am an advocate for finding the support you need.
Initially, when Elle was diagnosed, I didn't tell anyone. I think it was maybe like a week prior to his surgery. I told my mom and I told my sister, but I didn't tell anyone initially. I was like, oh my God, I don't know if I want to tell anyone this. But then, as it got closer, I shared it with my mom and I told my sister about it. And my mom was like, oh, there's like 5 guys at church, they had it. And then my sister started telling me about people from her church, So I felt better. And then I felt like I could open up and talk about it more, that, people do talk about it. So I just think that some people in the community don't think it's something that you should talk about, but it's okay to talk about it. It's okay to talk about it. And it's actually helped me, this older lady that goes to my sister's church, her husband had it. And, I feel so embarrassed saying this, but, she was like, she came up to me, which I didn't know that my sister had shared it with her. But I was like, wow, she told her. But I was like, okay, whatever. But she's like, she came up and she said, oh, your sister told me that Elle has, prostate cancer and he has to have surgery. She's like, it's going to be okay. She said, my husband had prostate cancer, 3 years ago and he's doing fine. She said he actually had a severe headache. He went to the doctor for his headache and they treated him for his headache and they did a complete physical and they found out he had prostate cancer. She said, I told him, one head saved the other head. And I was, and this lady had to be like about 70 years old. I was like, oh my God. I didn't know. I was like stone faced because I wanted to laugh, but I was like, but she was very serious when she said it. And when I walked away, I like bent over laughing. Like that was so hilarious to me. But, we can talk about it. We can talk about it. There's no shame in it. And like you said, hopefully, most people would be on the good side of it like we are. And there should be support for the people that, have a more severe case than Elle did.
vulnerability is a tricky thing in relationships and especially with strangers, right? Like part of men's difficulty in telling their partners that I have prostate cancer is you expect me to be around for you until you're old and ready to die. And I can't promise you that, right? That's a big hit to your role as a protector provider. I think sex plays a big role into relationships, intimacy. Mm-hmm. And I think there's a big need for people to be able to redefine what intimacy looks like after prostate cancer treatment, because even the anxiety or stress of going through it can make erectile dysfunction happen, right? Like just being psychologically distracted, worried about your own mortality or the outcomes of the procedure. Will I make it through the surgery, right? Mm-hmm. Can make people angry, mean, ornery. Yeah. So I think people don't talk about it because we don't like being vulnerable with our own wives. How are we going to be vulnerable with strangers, right?
Right.
Okay. So Dr. Adam, we want you to leave a ray of sunshine, some hope to the listeners. You know, we've been really, really heavy, and you know, prostate cancer is a very serious subject. But we want you to leave some sunshine for the listeners. Like, it could be okay.
The good news is that there's actual real rays of sunshine in prostate cancer. One thing that I'd say is that if you can catch prostate cancer early, it has like a 99% survival rate. So when you find it early, you can live a long, normal life. That's one. So get screened early and keep screening with your primary care doctor. Number two is a lot of data talks about how Blacks die more often with prostate cancer especially when they get metastatic disease that's spread all over. But it turns out that African Americans actually respond better to several treatments for metastatic prostate cancer and have a longer survival than American whites do. So when you're in treatment, Blacks do well stage to stage. And so I think that no matter what your color is, the field is moving forward towards better treatment, towards avoiding overtreatment by watching people when they're appropriate to be watched with active surveillance, and for treating people at the right time when their cancers say that they need to be treated. So lots of positive motion now.
Dr. Adam Murphy from Northwestern Medicine here in Chicago, among other assignments at the VA. We're very pleased to have you. An incredibly interesting and engaging conversation today. So thanks again for everyone for tuning in. So thank you very much.
Thank you. Thank you, Dr. Adam.
You're welcome. Thank you for having me.
To find out more information on the guest you just heard or previous guests and a list of Prostate Cancer Real Talk episodes, visit our website, prostatecancerrealtalk.com. And if you have a question, comment, or if you would like to share your story, send Elle and Shay an email, ellandshay@prostatecancerrealtalk.com. That's LEL and Shay, SHAY, @prostatecancerrealtalk.com.